It's appearing the live stream now.
Okay. So good afternoon. Welcome to the House Health and Government Operations Committee. The chairman is Chairman Pendergrass. I'm Vice Chair Peña-Melnick, and this is the Public Health and Minority Health Disparities Subcommittee. Edith, can you?
I got it.
Thank you. I just need you to mute. Thank you. This is the Public Health Minority Health Disparities Subcommittee. So we have a full work session today. The bills were posted. The members received the bills and the amendments. So we're going to start with House Bill 178, Public Health Cottage Food Businesses Annual Revenue. I know we have Delegate Chan. Erin, can you tell us what the bill does? And then Delegate Chan, you can address us. And Subcommittee, this is your opportunity to ask questions, okay? Like here and now, right here in this committee. If you have any concerns, let me know. So Erin, can you go ahead?
This bill, as introduced, would have increased the maximum annual revenues from the sale of cottage food products that a cottage food business may have from $25,000 to $100,000. There are amendments on pages 1 and 2 of your packet, and the amendments lower that $100,000 cap to $50,000.
Okay. Delegate Chan.
Thank you very much, Madam Vice Chair, and good afternoon to the entire subcommittee. Thank you to Ms. Hopwood, too, for all her help with this. Last week, we did have a meeting with the environmental health inspectors, and there was a compromise that was offered to have the amendment to $50,000 as the annual revenues, so from 25 to 50. So we appreciate the consideration, and it seems like that the health inspectors do appreciate about the rising inflation and supply chain issues and the rising cost of goods. So it sounded like that they were sensitive towards the industry and what the small business owners are going through, or the cottage food owners are going through, and trying to help them offer a little more assistance. So thank you so much to the subcommittee for considering this. Thank you.
Thank you. Is there anyone here that would like to be heard before I go to the members? Okay, I don't see anyone. Now, members, are there any questions that you have regarding this bill? Do you have any concerns? Does the fiscal note concern you? Are there any issues that you want to discuss? Delegate Johnson.
Thank you, Madam Chair, and thank you, Delegate, for bringing this bill. It wasn't a question, but I did contact the Department of Health, Webster, and ask him if we've had any complaints or issues with it when we went to 25,000 since then, and he said none. So I feel very comfortable going to 50. Thank you, Madam Chair.
My pleasure. Anyone else from the committee has any questions or concern about this bill? Okay, the bill has amendments. So is there a motion on the amendment?
Move the amendments.
Is there any concerns on the amendment or discussion? All those in favor say aye.
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 Any opposition? Seeing none, the bill as amended. May I have a motion?
Move the
Move the
bill
bill.
as
So
amended.
moved.
Is there a second? Is there any concern or discussion on this bill? Seeing none, all those in favor say aye.
Aye.
Any opposition, please raise your hand or unmute yourself. Seeing none, the bill passes. Do we have Riley or Shalega? They're not here, so can you please make a note that they were not here, okay? And do we have Chisholm on here? We don't have Chisholm.
We may have a lot of unanimous votes today.
Okay,
I'm on.
okay, your eye on this one, Delegate? Great.
I'm good with the bill.
Okay, beautiful. Thank you so much. I appreciate you. And Riley and Shalega are missing right now. Okay. So Chisholm is
Shalega-
here.
Shalega just-
I'm
All
here.
right, Shalega. So how are you on this bill on 178? What they did was basically increase the cap from 25,000 to 50,000, and Delegate Chan worked it out with the department.
Good.
All right,
I'm very much in favor.
beautiful. Thank you so much, and I appreciate it. So that's unanimous with the exception of Delegate Riley, who's not right. She'll probably get in shortly, okay? The next bill is House Bill 293, the Behavior Health Crisis Response Services 988 Trust Fund. And for the members, we have had this bill already like 3 times or something like that, waiting on the fiscal note. And there is an update. So Aaron, will you tell us what that update is? And then Delegate Lewis Young, will you speak with us? And by the way, there was a huge article in the New York Times this weekend on 988. I think it was this weekend. So go ahead, Aaron.
So the bill would establish the 988 Trust Fund to provide reimbursement for costs associated with designating and maintaining 988 as a universal telephone number for a national suicide prevention and mental health crisis hotline, and developing and implementing a statewide initiative for coordinating the delivery of the continuum of behavioral health crisis response services. This was discussed last week in subcommittee. It came down to the level of funding to be authorized or to be required by the governor. And if you look on handwritten page 7 of your packet, the bill as introduced would have required the governor to include $10 million to fund the program, and that has been reduced to $5.5 million. This is the way that the bill has passed Senate Finance Committee.
All right, Delegate Lewis Young, would you like to be heard on this bill?
Thank you, Madam Chair. I'm here to answer questions about what the bill does in case anyone needs refreshing of their memory. But there was pretty uniform agreement that we need to move forward with this suicide hotline. The only issue was the funding, and that seems to have been resolved.
So just for the committee, tell us why this bill is so important.
Okay. Well, first of all, it was mandated by the federal government, an independent suicide hotline. It takes calls away from other lines that are focused on multiple other issues. For example, a lot of suicide calls go to 911, and law enforcement is not necessarily the best place to handle it. This will now be handled at a local level at 8 of our call centers, and these calls will be prioritized given this 911 hotline.
And those 8 local centers, where are they?
I know one's in Frederick. I'm not sure the exact location of the other 8.
But it's safe to say that they're through the state?
Exactly. That's
Okay.
fair.
Okay, I'm gonna open it up for questions now. Delegate Shalega, followed by Delegate Johnson.
Thank you. So I noticed
My
in the
pleasure.
fiscal note, it's down to a $5.5 million. Is any of
Yes.
that federal? Is it matched, or is it all coming from us? And is it coming from the general fund, or is there a fee associated?
There's no fee associated with it. While other states are doing fees to telephones, cell phones, we decided not to go that route. So that is before a federal match.
Erin, where's the money coming from?
So the 5.5 is general funds. There is federal money, almost 2 million in federal over 2 years, but that's not related to the 5.5, the governor in this bill.
And if I remember correctly from the testimony, there was concern that there isn't as yet an adequate advertising for this, so people won't know that this is even an option. What can you tell us about that?
Dan Rabbit's on this call. I think he's the expert on the funding.
Yeah, I'm happy to share some information. Hello, delegates. So the 5.5 comes. The state convened a planning coalition like the Behavioral Health Administration, as well as stakeholders. And they determined the state needs at least $7.5 million. And we're getting 2 million from the federal government. And so that's how we landed at 5.5 for the trust fund. And in terms of the promotional campaign, the federal government is almost certainly going to launch a national promotional campaign, like marketing campaign. And we want the state to coordinate with the federal government, and they're going to be singing from the same songbook. And that's all that the legislation says, is that the state will coordinate with the federal government to ensure an effective promotional campaign. But we think the federal government will do a lot of the heavy lifting for that. And what the state wants to do on its own to promote 988 is not mandated or directed in this bill.
Is this a one-time 5.5, or are we talking about an annual continual appropriation? One time, I see Erin holding her finger up. And I'm assuming there's a report. I think I saw in the reprint or in the bill that there's a report due back to us. Here it is on page 4. All right. Thank you.
Thank you. Okay. This bill, is it safe to say that the governor's office was part of this discussion? Mr. Rabbit? You said that the state convened a planning coalition with governor's office. Is that what I heard?
Yeah, the Behavioral Health Administration convened it.
Yeah.
So, and that was the number that they landed at.
All right. So the answer is yes. Thank you. Delegate Johnson.
Thank you, Madam Chair, and thank you, Delegate, for bringing this. I would like to know, is this a temporary fix until they get the 988 up and running, or how will this merge with the 988? From what I understand, all the national advertising is going to be on the 988, not the 211. So if somebody could just kind of address those.
So this is the trust fund, the number needed for the state and the federal government to establish the 988. This is the bill that would authorize the coordination between the federal and the state and provides the funds. 5.5 million from the state, 2 million from the federal government. It's a one-time appropriation from the general fund. And this is the vehicle to get that started. Am I right, Mr. Rabbit?
Yes, this is what we estimated we need to be prepared for when the new number launches. And there is a report required in the bill, and we'll reassess when we get a little further down the line to see what the state needs.
Okay, thank you, Madam Chair.
My pleasure. Heather Scheck from the Maryland Department of Health. Welcome, Heather.
Hi, thank you. Thank you, Delegate. Good, thank you.
Good.
Just to expand a little bit on the answer for Delegate Johnson's question, we are, the department, the plan is to start moving from 211 to 988 being the primary system since it's required by the feds. 211 will not go away. So if they don't know about 988 and they call 211 press 1, they will still reach someone and be connected to someone. But the idea is to move towards 988.
But 211 does more than just a suicide hotline. 211 people call for all kinds of stuff, right?
Correct.
Which is why it's not going to go away.
Correct.
Okay.
Correct.
Right. Great. And Heather, are you supporting this bill?
We are no position on it. We're not opposed to it, but we are, of course, because it's a mandatory appropriation. But we're not opposed to this bill.
Okay. All right. Great. So I can say no, not opposed. Okay. All right. Beautiful. Any other questions for this bill? Any questions regarding the fiscal note? Any question regarding anything? Delegate Chalega, are you?
Yes, I pushed that face. I don't know how I did that.
It's okay.
But I didn't do that on purpose. I was trying to find my hand.
It's okay.
I clicked too fast. So I'm assuming, Dan, there's a budget. Like, where did you get to $5 million? And, what's the rationale for that number? Give us some justification on the budget, please.
Sure. So, the planning coalition that Behavioral Health Administration convened met throughout 2021. They did a landscape analysis. They surveyed the current call centers that are a part of the network that will answer 988 calls. They looked at national estimates, and they came up with a range between $3 and $17 million. And they, did their best to kind of check out all the different estimates. And they determined that $8 million is what's needed, and that the state currently provides $500,000 to these call centers. And so 8 minus 500,000 is 7.5. And then the federal government is providing $2 million through a formula grant. Like the state hasn't received the money yet, but we're almost certain that they will. And so 7.5 minus 2 is 5.5.
So how long will this fund the program for?
We think that this will get us through FY24, and then we'll reassess and see if additional state dollars are needed to maintain or expand capacity go from
So
there.
that's for 1 year. Does that mean you'll be back the next year for another 5 million, or?
It depends on whether these estimates were right. It depends on how much money the federal government provides. We think that this $2 million that the feds have provided is just a start. And so we're hopeful that additional funding could come through. We know that the Hogan administration also has been considering how to use Medicaid to support some of these funds. Like, not sure how much that will help with call centers, but there's a lot of different moving parts. And so I think it's just hard to say where the funds will come down the line, but we think that this is good enough to get us through FY24 while maintaining the high level of in-state answer rate that we currently have, and maybe improving it.
Okay, and one last question. Which department is running this? Who's running this?
The Behavioral Health Administration manages the trust fund.
So they're the ones where the buck stops with them and they're awarding contracts and all of that.
Yep.
Thank you.
And is this 988, is it a mandate from the federal government, like all states have to do it?
It's a mandate to all the telecommunications companies. All the phone companies have to be able to route calls made to 988 to local calls to the national system, and then that national system has to route it to the local call centers. So that's the most basic of the mandate, but it is very strongly recommended that all states prepare. Almost every state convened a planning coalition, and almost every state is looking at what sort of state resources they can cobble together to make sure that they're ready when it launches. And it launches in July of this year.
Okay. All right. Any other questions? All right. Seeing none, the bill does have amendments. So is there any questions or concern on the bill before we go on? All right. Is there a motion on the bill?
Move the
On the
amendment.
amendments? Thank you. Is there a second?
Second.
Any questions or concern about the amendments from the committee? All right, seeing none, all those in favor say aye. Any opposition? None. On the bill as amended, is there
Move the
a
bill.
motion?
Move the bill as
Favorable.
amended.
Okay, it's been
Second.
moved in second. Are there any questions or concern from this committee on the bill as amended? This is your opportunity now. Seeing none, all those in favor say aye. Any opposition? No opposition. Is Delegate Riley back?
No, she isn't.
Okay, Erin, can you please know the file? I just want to make sure I represent things
Yeah,
correctly.
I wrote
Okay?
it down.
Yeah, I don't want to misspeak and misrepresent. So thank you so much, everyone, for your work and Mr. Rabbit on it. Now we have House Bill 746. Maryland Medical Assistance Program, Gender Affirming Treatment, Trans Health Equity Act of 2022. This is jointly assigned with appropriations. Aaron, can you tell us what the bill does? And then Delegate Kaiser, I will need you to tell us why we need the bill. And then I will open it up for the committee to express your concerns, to talk about it, okay? Aaron.
It's actually not jointly assigned with appropriations.
Is not? Okay.
Oh, it's just
I
one that
misspoke.
we would just run through by appropriations.
Thank you. I appreciate the correction. Thank you so much, Aaron.
The bill would require Medicaid beginning January 1st, 2023 to provide coverage for gender affirming treatment in a non-discriminatory manner. By December 1st of each year, each Medicaid managed care organization must submit a specified report to MDH. And by January 1st of each year, beginning in 2024, MDH must compile an annual report on geographic access to gender affirming treatment across the state. There are amendments in your packet on handwritten pages 8 through 13. If you look on page 10, a lot of the specific procedures in the definition of gender affirming treatment have been stricken. So it's less specific as to what procedures will be required for Medicaid reimbursement. If you go to handwritten page 11, starting on line 14, it defines gender affirming. The gender affirming treatment may include treatment described in the current clinical standards of care for gender affirming treatment published by the World Professional Association for Transgender Health. It strikes language stating that gender affirming treatment may be prescribed to transgender, non-binary, intersex, two-spirit, and other gender diverse individuals. And there's kind of replacement language for that in a new subsection B under line 21 that provides it is the intent of the General Assembly that Medicaid provide gender affirming treatment to all Medicaid recipients for whom gender affirming treatment is medically necessary, including transgender, non-binary, intersex, two-spirit, and other gender diverse individuals. Moving on to handwritten page 12, after line 3, provides that Medicaid may not deny or limit coverage for gender affirming treatment based on the Medicaid recipient's gender identity. There's also new language providing that Medicaid may not establish a categorical exclusion for a particular gender affirming treatment. And that is it for the amendments.
Okay. Delegate Kaiser, can you tell us why this is important?
Thank you, Madam Chair. Hope people can hear me. My internet is not.
We can hear you.
My internet is not awesome today. I just want to point out that the treatment that we're talking about in this bill is supported by major medical institutions, and it's really necessary for transgender individuals. And also, this is about gender dysphoria, people who have, not only people who have undergone a sex change, but others who appear as transgender. And we're talking about a small number of people. We're talking about ensuring that other procedures that go along with appearing as the changed gender are also covered. And I want to say the bill only covers treatment when a medical provider confirms that it's medically necessary. So that safeguard is there as well. And that also much of this care still requires a psychiatric assessment of clinical necessity. This is not something that would cause a huge cost. Obviously, there's some cost here with some federal funds covering things as well, but we're talking about a small number of people needing a small number of procedures. So I can answer some questions as well. And I have a few experts here also.
Okay, great. Is there anyone that wants to be heard before I open it for the committee for questions? Any advocates? Okay, I'm going to open it up for questions now. Delegate Shalega, followed by Delegate Chisholm.
So I'm reading in
pleasure.
the reprint on handwritten 11. What is two-spirit? It says necessary, including transgender, non-binary, intersex, two-spirit, and other gender diverse individuals. Can you tell me what two-spirit is and what other gender diverse individuals are, please?
Sure. I think the best person to answer that is Sam Williamson. And I think the terminology other gender diverse individuals is a cover for like an et cetera. But Sam, I think, is best to answer that question.
Happy to answer. So Two-Spirit is a specific identity that is tied to Indigenous, so Native American folks in the United States. And so it's for people who, it's similar to what we would, like I identify as non-binary, so not a man, not a woman. So Two-Spirit is very similar, but it's tied to specific Indigenous cultures. And Delegate Kaiser is absolutely right. The reason that we have other gender diverse is because, as some of you may know, the language on this does shift and evolve over time. And so we wanted to make sure that this bill isn't tied to a specific, it doesn't become dated as the terminology around transgender identities continues to evolve.
Is there a minimum age for this? Is this 18 or?
Well, I just to be clear, this bill does not affect youth in Maryland. Youth cannot those under 18 can't access surgeries. They can get puberty blockers, if you really want to know, which are fully reversible. But even then, they can only receive that care when they have parental consent. So for all the talk about parents having all the rights, in this case, parents have full rights with children under 18, but parents want this for their children when they know it's best for their children.
Okay, and lastly, I would ask, would this allow, so for instance, you know, I have a friend who's an adult female who she's a woman and has occasionally been called a man because she's very flat chested. She's just a straight white lady. Could she have a breast enhancement under this bill? Would this open up to anyone who's straight or gay or any of the other classifications? Could they seek a breast enhancement if they wanted it?
I don't believe in that exact scenario, but certainly reconstructive surgeries after mastectomies. So I think, but what we are trying to do here is to help a community that's often carved out of different rights, including healthcare equity. And because of particular concerns within the transgender community on how some health issues, how they're treated by others and the harassment they get and so forth. So that's why we are particularly looking at this community.
Yes.
So to answer, if I may, Delegate Shalega, if you look up page 4, I mean, a small page 11 of the reprint, which says bill page 4. If you look at line 29, it says the intent of the General Assembly that the program provide gender affirming treatment to all program recipients for whom gender affirming treatment is medically necessary. So your friend wouldn't qualify if your friend is not seeking gender affirming treatment, and if the doctor does not state that it's medically necessary as well. So it would not be open just to anyone.
How could it not be gender affirming? She wants to be affirmed as a woman, and this will affirm her gender as a woman. I'm not sure legally you could prohibit straight women who wanted a breast augmentation from having one.
Well, Sam, can you address that? Sam has an answer.
Yes, Chair, I'd be happy to. The operative provision there is on medically necessary. And so these procedures are medically necessary according to very particular standards that talk about transgender healthcare needs. And so it's not that we're prohibiting people based on their identity from getting care. It's that it is only medically necessary if you meet very strict criteria, which your friend would not meet. And that is why this bill would not cover that type of treatment. It is for very specific medical needs that have a very huge impact on the transgender community and will help reduce rates of suicide and other sorts of medical issues that folks are facing.
Yeah, I'm thinking this is discriminatory because it would still be gender affirming, but maybe we could get an attorney general's opinion, because again, a woman who wants to be affirmed as a woman, who would, you know, a physician could say this is medically necessary because she is oftentimes mistaken for a man, and she would like a breast enhancement or augmentation. I don't know how you could discriminate against someone because they're straight. So I would like to see an attorney general's opinion on that.
Well, Delegate Shalika, with all due respect, this bill is about not discriminating
Transgender.
against the trans community who currently are being discriminated against. It's trying to bring them up to everyone else. So
Yeah, I understand, but I still am not sure that it's not discriminatory to not allow straight women to have access to that as well. Thank you.
Because, and if I may, and we can seek your opinion, but a straight woman that will get breast enhancement, that's considered cosmetic. This is different because this bill is drafted for transgender individuals where the language is medically necessary. And I will bet that the Attorney General opinion, and this is putting my legal hat, although I'm not an Attorney General, will probably come up with that language that in your friend's instance, it is cosmetic, which is very differently defined in medical books as opposed to the transgender community. But we can, Aaron, you can seek an AG opinion, please, and ask the following question. A woman that wants to get affirmed as a woman who's straight, okay, would she under this bill qualify to get a breast enhancement? Is that your question, Delegate Shalika?
Yeah, if it is gender affirming, she feels like her gender isn't, she's being discriminated against because people think she's a man and she's a woman. And so it is a gender affirming surgery in the same way that it would be for a transgender woman. Could they be disqualified or discriminated against? And it's the same exact motivation. It's, I just don't know how you couldn't let a straight person affirm their gender and only let a transgender person affirm their gender. Thank you.
Okay, so Aaron, thank you for doing that, for seeking it. Any other question, Delegate Shalika?
That's it for now. Thank you.
Thank you. Delegate Chisholm, followed by Delegate Johnson, followed by Lewis, by Bill Castro, by Bagnell.
Thank you, Madam Chair.
My pleasure.
And I'm sticking on the same portion of the reprint. I wanted to ask this before we got too deep into it, and I know that some of it was just covered, but when we're talking about medically necessary, somebody said that, they're very strict standards. Do we know can we get an idea of what these standards are? And I don't know if that's something.
We have a Dr. Baker here who can answer that question.
Thank you, Delegate Kaiser. Thank you,
Yes.
Madam Chair.
My pleasure.
Delegate Chisholm, thank you for your question. With regard to the expert medical standards that guide the provision of gender affirming care for transgender people, this is in relation to a diagnosis called gender dysphoria, which has been in the International Classification of Diseases for many decades now. The first time the standards of care were published was actually in 1979. So they have been around actually longer than I have by a couple of years. And they are the controlling guide that clinicians around the world, as well as in the United States, look at when determining the medical necessity of care related to gender affirmation. With regard to the conversation around accessibility of this care for both transgender and non-transgender people, there's a well-accepted standard of parity in insurance coverage that similarly situated individuals may not be treated differently on the basis of factors such as sex, and in this case with this bill, with regard to gender identity. The concept of parity and the availability of treatments for cisgender, meaning non-transgender people, is very well established. There are many safeguards in place to ensure that if a clinician, if a physician deems a treatment medically necessary for a cisgender, a non-transgender person, that they will be able to access those services. The exception is transgender people. As was previously noted, there is a carve-out for transgender people that expressly says that procedures that may be medically necessary for non-transgender people can never be considered medically necessary when you're talking about a transgender person. And that is the issue that this bill seeks to resolve, that there is already a standard of parity that says if you have a medical condition that is diagnosed by a physician and is following accepted expert standards of care, you can get coverage for that procedure unless you're transgender. And that is the kind of discrimination and the kind of imbalance that this bill seeks to resolve.
Can you, and I'm sorry, I'm trying, my mind's racing, trying to come up with an example of what you're.
1 second, Delegate Chisholm, may I have a quick follow-up on that just so that it can clear it up for all of us? And where is that carve out, Dr. Baker?
The carve out for transgender people?
Yes.
The specific exclusions that remain in Maryland law.
Okay.
Can you give me an example, Dr. Baker, just so I can maybe wrap my head around it, of something that, a procedure where a cisgender is getting coverage, but a transgender is not?
Sure. There are a very small number of insurance mandates at the federal level, because in general, insurance regulation is reserved for the states. But the federal government has noticed that there is a particular example that I think is relevant here that is such a major issue for the health and well-being of women that it is covered by federal law, which is breast reconstructive surgery following prophylactic treatment or treatment for cancer. So there is already a well-recognized, I would say, protection or standard, even at the federal level, quite apart from the many, many protections that exist at the state level, to ensure that people who need access to this gender-affirming care can get it. But that has not been the case for transgender people. The medical necessity of care for transgender people has been, I would say, occluded, has been specifically overlooked, despite the long-standing existence of the expert standards of care, because of a lack of recognition of who transgender people are and what their healthcare needs are. And so this is about revising that long-term omission to ensure that transgender people are included in the same standards of parity and have the same protections as non-transgender people.
Thank you, Doctor. Thank you, Madam Chair.
Thank you for your questions. Delegate Johnson, followed by Lewis.
Thank you, Madam Chair, and thank you, panel, for trying to help us understand this more. My question is, I still didn't see the standards. I looked under gender dysphoria, and I still really didn't see standards. And kind of along Delegate Chisholm and Delegate Shalega's question, is it says medically necessary, but as I look over the list, most of this looks like cosmetic surgery. So what
That has been reduced. Are you looking at the reprint?
Yeah, all the procedures have been deleted.
Have been deleted.
Okay.
Yeah, look at the reprint.
Yeah, I didn't get that in the reprint. Okay. All right. So is there somewhere that we can find these standards under that gender dysphoria that you were talking about? Anybody that can answer that question?
Delegate, Dr. Baker.
Thank you, Madam Chair, and thank you, Delegate Johnson, for the question. The standards of care are publicly available. I won't speak for my colleagues, Sam and others, but I know that they are publicly available. They have been published in the peer-reviewed literature, and they are currently in their 7th edition. As I mentioned, they were first published in 1979 and have been continuously maintained and updated. The 8th version of the standards of care is to be published later this year. I was part of the team at the Johns Hopkins Evidence-Based Practice Center that conducted the scientific review of the evidence underlying these standards. And so I have great confidence that they are based on the most up-to-date medical and scientific evidence in relation to transgender health.
All right, thank you. I know what we're trying to do here. I'm just trying to make sure we have the information. So thank you. Thank you, Madam Chair.
Dr. Baker, can you send us the standard of care? Are you able to send it to the committee? Send it to the language to.
I will be.
I think that is what I think that's what Delegate Johnson would like. Okay.
Yes.
And then Aaron, can you send it to the whole committee, please?
Yes.
Thank you. Thank you so much for doing that. Delegate Lewis, followed by Bagno.
Thank you, Madam Chair.
My pleasure.
Thanks again to the bill sponsor. It occurred to me during the questions about the hypothetical proposed by the good delegate from Harford County about a, hypothetical case about a straight woman. And I wanted to make sure I understand what we're really talking about. So my understanding is that the straight woman who is perceived by the world, by other people as looking like a man, is she transgender because the world perceives her, or is the transgender identity something that is experienced internally? For example, I think of, just take myself for an example. I know that I'm, I don't have, I know who I like, and I know that my self-concept fits with the body I have, could someone explain why the hypothetical of the straight woman perceived by others as a man is different than a person who perceives themselves to be a man in a different body? Can we
Dr.
talk,
Baker.
someone explain that?
Thank you, Madam Chair, and thank you, Delegate Lewis, for the question. I appreciate your raising the opportunity to talk very briefly about sexual orientation and gender identity. Sexual orientation, according to the National Academy of Sciences, is a different and distinct construct from gender identity. So sexual orientation being about who you are in a relationship with or who you are attracted to, gender identity rather being the internal, deeply seated self-concept of who you are. And so there is no psychiatric diagnosis associated with sexual orientation. There used to be. It was removed from the Diagnostic and Statistical Manual in the early 1970s as the medical field came to realize that diversity of sexual orientation is in fact a variety of natural human existence. The diagnosis of gender identity disorder or gender dysphoria does remain in the medical literature because it refers specifically to the clinically significant distress that accompanies a difference or a misalignment between someone's sex that they were assigned at birth and their core innate sense, their knowledge of who they are. And so when it comes to the question of someone who is not transgender having issues with their gendered appearance, that, and I do agree with Delegate Zaliga, that can be considered gender affirming to make sure that you are seen to be who you are. But cisgender people, by definition, do not experience gender dysphoria, which is that misalignment between the sex that they were assigned at birth and their deeply seated, deeply held and innate notion of their gender identity. And so for a transgender person, that care rises to the level of medically necessary because of the clinically significant distress that accompanies that difference. It is certainly important for everyone to be recognized in their right gender, which is why, as I mentioned earlier, we have the federal insurance mandate about, for example, breast reconstruction. And so this bill is about making sure that transgender people can access the procedures that they need for gender affirmation in relation to a diagnosis of gender dysphoria and a documented medical need that is prescribed, noted by a physician.
Thank you so much, Madam Chair.
My pleasure. Delegate Bagno.
Thank you, Madam Chair, and thank you once again to the bill sponsor. I don't know who would be best to answer this question, but is there anyone who can speak to the suicide and homicide rates of transgender men and women, and particularly transgender women of color, so we can better understand the risk factors around gender dysphoria?
Delegate Bagnell, I have some statistics, and I do think possibly the advocates can provide some more in terms of the that transgender individuals are 40% more likely to attempt suicide. They're 4 times more likely to be victims of violent crimes. And I think that generally is because people who look at them and feel uncomfortable and then for whatever reason take it that next step to want to assault them. The vast majority of LGBTQ students report harassment based on personal characteristics, including sexual orientation and gender identity. And I mean, you hear situations of I think in some cases, just transgender people being, what's the right word? just being shunned by their friends and family, maybe kicked out of their home, and you're dealing with so many other issues because of other people's discomfort with them being trans. Again, we can probably get more statistics on that, but thank you for that question.
Thank you very much. Madam Chair, Margot Quinlan's hand went up. Would it be okay if she answered this
Sure.
question? as well?
Sure.
Great, thank you, Madam Chair and Delegate Bagnall for the question. And just to clarify, I am Margot Quinlan with the Mental Health Association, and it's an important question to ask because I think something that sometimes gets lost in the really alarming and frightening statistics that our community faces is that when we talk about gendering and how we experience gender, a lot of times for us, we sort of gender one another based on immediate outward appearance, right? And so a lot of this care for us is, it's as Dr. Baker was saying, it's addressing this sort of internal recognition for the trans community, but it's also around safety and reducing discrimination and harassment in the community, which many of us do face. And so this care can really alleviate that. And from our position at the Mental Health Association, I mean, we see the research is extremely clear that when we reduce the impacts of discrimination, of harassment, of minority stress that the trans community faces, that it really can have net positive, life-saving benefits for the mental health and wellness of the community.
Thank you very much.
And if I may ask a question of the doctor, so this bill really, it's for someone to be able to avail themselves of this legislation, if it were to pass, you will have to be diagnosed with gender dysphoria, correct?
You would have to be under the care of a clinician who is prescribing these treatments in accordance with expert standards in the field, yes.
Okay, so that's, thank you. That's pretty clear. Thank you. Delegate Chisholm, followed by Delegate Shalega.
Thank you, Madam Chair. And I'm familiar with the statistics that I think Delegate Kaiser just gave, and we're all in the same boat trying to curb a lot of the suicides we see. But I do have a question. Do we have any, I know it was 60%, do we have any statistics to showing a decrease after some of the gender affirming surgeries, or if there's a massive decrease? And if so, can it just be, when we get the other study, can we get some of that as well? Or if Delegate Kaiser can provide that to the committee, that would be great, or anybody else.
I think that's one of those cases of it's hard to have data on something when it doesn't happen. So kind of the contrapositive, as it's known in logic terms. So I'm not sure if that's available, but if it is, we will look for it. And I think Margot Quinlan and Dr. Baker both may have an answer to that.
I'm going to ask Quinlan, go ahead.
Okay, thank you. Yes, I'm more than happy to follow up. There is data that demonstrates the reduction in depression, anxiety, suicidal ideation in youth and adults when receiving gender affirming care, and more than happy to help follow up. We'll sort of bundle everything and follow up with those materials.
Thank you.
Thank you so much. Dr. Baker.
Thank you, Madam Chair and Delegate Chisholm, for your question. I just wanted to echo Margot Quinlan's comment that yes, there is a substantial body of data indicating that access to gender affirming care does improve a variety of health outcomes for transgender people. For example, it improves access to HIV prevention interventions, it improves quality of life, reduces anxiety, reduces depression, and reduces suicidality. And so we will be happy to follow up with some of the literature in that area.
Thank you. Thank you, Madam Chair.
Thank you for the question. Any other questions or concern regarding this bill? This is your time right now because we have everyone at the table. All right, so this is the plan for this bill. Aaron will seek an Attorney General opinion regarding what Delegate Shalega brought up. Margot Quinlan and Dr. Baker will give us, Dr. Baker, the standard of care language. Margot and Dr. Baker will follow up and give us the data regarding how this actually would help reduce the number of suicide, depression, and anxiety as well, and any other data that you can get, okay? Any other questions or concern from the committee that you will like? All right, seeing none, we will go ahead and hold the bill. This committee's meeting again on Wednesday, so Dr. Baker and Margot Quinlan, if you could send us that today, that would be wonderful, and Aaron will send it to the entire committee. Let's move on to House Bill 669, Office of the Chief Medical Examiner, Grief Counseling Services. We're gonna hold that bill. The sponsor of the bill has asked us to hold it. So we're gonna hold that bill along with House Bill 746. House Bill 775, Maryland Pediatric Cancer Fund Establishment and Income Tax Checkoff. There are no amendments in that bill. Aaron, could you please tell me and tell the committee what the bill does?
The bill would establish the Maryland Pediatric Cancer Fund checkoff on the individual income tax return form. The bill also establishes a Maryland Pediatric Cancer Advisory Committee, and that committee will, they are the committee that would review and evaluate requests for funding from the from the Pediatric Cancer Fund to identify innovative projects that are eligible to receive grants from the fund.
Is there anyone here to speak on this bill, advocates, before I actually open it up for the members? Okay, are there any questions from the members regarding this bill? Okay, seeing none, is there a motion on the bill?
Move the bill. Second.
Okay, it's been moved in second. Any questions or discussion or concerns? Delegate Shalega.
Sorry, I couldn't get my hand up fast.
It's okay. We're here for this, so don't worry about it.
All right, the fiscal note on it looks like it's just 24,000. And that's just set up the checkoff. Other than that, I think, is that right, Aaron?
I see 82,000 in 2023, and then 28,000 in 2024.
Okay, I see. I read down too far. So the beginning's to set it up, and then
Yes.
after that, they
Just
need
on
a half of a
maintenance.
person to disperse the grants. Okay.
Mhm.
All right, thank you.
And it's
My
jointly
pleasure.
assigned with Ways and Means, so Ways and Means will have to sign off on this as well.
Thank you. Delegate Hill.
Thank you. I'm sorry I had to leave and come back. Can you just remind me what bill we're on, please?
We are, Delegate Hill, on House Bill 775, which is the Maryland Pediatric Cancer Fund Establishment and Income Tax Checkoff.
Thank you very much.
And we just discussed the fiscal note, which is less than $100,000 to establish.
All right, appreciate it.
Anyone
Thank you.
else? My pleasure. Anyone else? All right, seeing none, may I have a motion on the bill?
Move the bill.
May I have a second?
Second.
It's been moved in second. Any questions or concern? Delegate Hill, your hand is up. Is it just from the last time? Yes? Okay. All those in favor say aye.
Aye.
Any opposed? Seeing none on the bill, there are actually no amendments on this bill, right? Was I
Correct.
right? There were no amendments.
No amendments.
So a motion on the bill, may I have a motion on the bill, just straight? Okay, again, can you unmute yourself, Delegate Rosenberg?
Move the bill.
Thank you. May I have a second on the
Second.
bill? It's been moved in second. Any opposition? Any concerns? Seeing none, all those in favor say aye. Any opposed? Great, the bill passes unanimous. May I have, let's do House Bill 915. There are no amendments on that bill. It has passed the Senate. Erin, can you describe the bill, please? I mean, it's passed the subcommittee in the Senate.
It passed Senate Finance.
Senate Finance, okay, great.
The bill requires the Maryland Healthcare Commission to designate a patient safety center for the state by December 31st, 2025, and establishes a patient safety center fund to subsidize a portion of the cost of the center. For fiscal 2023 and each fiscal year thereafter, the governor is required to include in the annual budget bill an appropriation of $1 million for the fund. The Maryland Healthcare Commission may provide a grant from the fund to the patient safety center. There are no amendments.
Is there anyone here on this bill that wants to be heard?
Madam Chairman, I just
Yes.
wanted you to know this is Dr. Blair Ige, the president of the Maryland Patient Safety Center, and I'm here to answer any questions that anyone may have.
Okay. Any questions regarding this bill? Since the doctor is here, this is your opportunity. Any questions or concerns regarding this bill? Delegate Shalega.
Thank you.
My
If
pleasure.
the doctor can just give us a summary of what the Patient Safety Center is and whatever other information he may have.
Thank you, Delegate Shalega, for the question. Doctor, will you be so kind and address the delegate's question?
Absolutely. You're going right to something I'm passionate about. The Maryland Patient Safety Center was created by the legislature in 2004. And then since that time, the Maryland Healthcare Commission has designated the Patient Safety Center every 5 years. And we, the Maryland Patient Safety Center LLC, have been the Patient Safety Center since its inception. And were redesignated almost 2 years ago through 2025. We bring together, we're a convener, we bring together healthcare entities across the state. It's been mostly hospitals, but now with a lot of work in the outpatient setting and the need for patient safety in the outpatient setting, we've been working with nursing homes, with clinics like federal qualified health centers, in addressing major issues of patient safety across the state, including most recently infection control, especially in nursing homes, as we've seen during the pandemic, in support of healthcare staff. In our Caring for the Caregiver program, we do in conjunction with Johns Hopkins, which is support of healthcare staff during times of stress. And as we know, the last 2 years have been very stressful. And our newest programs in healthcare equity, addressing disparities in healthcare, a specific interest of this committee, for both initially COVID vaccine hesitancy in healthcare staff and communities of color, and more recently in the disparities seen in complications of pregnancy in Black women in Maryland. So we address the issues that need to be addressed and that are in conjunction with the Department of Health, the Healthcare Commission, and up until recently with the HSCRC. We have been funded in part by the HSCRC since our inception, but that was mostly seed funding that has now gone away. And that is why we're coming to the legislature to continue that funding so we can continue to address these issues.
Thank you, Doctor. And so the HSCRC will continue to administer the program and the general fund will fund it. Is that what I'm hearing?
Thank you for asking. Now the Maryland Healthcare Commission will manage the funding. The funding will come through the Healthcare Commission, no longer the HSCRC. The issue with the HSCRC, of course, has been that funding is related to hospital financing across the state, and therefore funding would come out specifically from patients of hospitals and not from the entire state. So the intent the HSCRC had was helping us get started, and it went on for very long, obviously, but was to move it towards other sources of funding that would cover the entire state, not just hospitals. So we are funded by hospital membership. So hospitals are already funding us. But in terms of general funding, to support these programs I mentioned, it is to move from HSCRC funding to general funding from the state. And therefore, this will be administered by the same the commission that also designates us, the Maryland Healthcare Commission.
Thank you. Thank you so much. And I see Ben Stephan's hands up.
Yeah.
I was going to ask you, Ben, we had a fiscal note where you asked for an increase in fees. Is this one of the reasons that you needed an increase in fees?
So thank you. Thank you, Delegate. So this fund the funds to support the Patient Safety Center will come from general funds. We are given the ability to award grants to the Patient Safety Center if a need is identified. The 15 members of the commission, governor appointed commission, support the use of general funds for this purpose. I just want to very briefly echo the importance of this. The intent all along was that HSCRC would help fund it, but the scope of the Patient Safety Center's duties go beyond hospitals. And in fact, the commissioners have been very emphatic that they move beyond hospitals, and they are doing that to focus on nursing homes, ambulatory surgery centers, et cetera, that are not necessarily owned by the hospital system. So the Healthcare Commission is very supportive of continuing the funding of the Patient Safety Center. We monitor the work of this Patient Safety Center. There are semi-annual reports and periodic presentations to the commission that are done. And we think this is an important and valuable use of state funds for patient safety.
Thank you both.
Thank you. Any other questions or concern regarding this bill? This is your opportunity right now. Okay, seeing none. Okay, the bill does not have, actually, it has no amendments. So Ben, your hand is up. Did you want to say anything else?
No, I'm removing my
Okay.
hand, taking my hand.
Okay, no problem. Since there are no,
Chairman.
yes.
Oh, hi, this is Delegate Sample Hughes. Just wanted to make the committee aware, if it wasn't mentioned before I jumped on, that it did pass out of the Senate. So that is a unanimous vote.
Thank you so much for letting us know, Delegate. We appreciate it. Is there a motion on the bill?
Move the bill.
Second.
May I have a second? It's been moved in second. Any questions or concerns? All those in favor say aye.
Aye.
Okay,
Aye.
any opposition? All right. Is Delegate Riley here? Can you please note the file,
Not
please?
yet.
And remind me? Thank you. All right. Now we're going to House Bill 1020. Delegate Lewis Young, you have 5 minutes that you wanted to address the committee. You can have it. Then we're going to go ahead and let the department, Heather's here. Heather? Okay, the department speak, and then Aaron, and then we'll open it up. Delegate Young, go ahead. And we have a hard stop at 1:25 because you guys know where you need to be, right? Something sweet. Okay, go ahead.
Thank you very much. This bill is back for the third year. The one thing that's significantly different this year is the product of a work group, which met for 7 months. And that's predominantly what I want to share with you all, because we had 22 people, including 2 people who are sitting on this subcommittee, who worked long and hard to develop some good recommendations for individuals that choose to utilize self-direction. So this bill first came, as I mentioned, 2 years ago. Last year, it had a very big fiscal note. And the rationale for that was that CMS would not permit some of the items we asked for, and therefore it was going to be very expensive. A good deal of the work done by the work group was to dispute that claim. And we did several times over. We had a number of people from CMS and cited CMS regulation wiping that rationale out. So as I mentioned, the work group met for 7 months. There were 22 members. However, on the average, we had 50 people at each work group. We had a lot of input from the public, in particular, individuals who utilize self-direction or their family members. Nevertheless, we broke out into 2 subgroups because we wanted to give users and family members ample time to air their concerns. Also, one group was strictly devoted to CMS regulations and what would cover. So let me run through quickly the 7 recommendations, and several have already been agreed to by the Maryland Department of Health. Case managers from community services will be better trained in self-direction and will fully orient new and current participants about self-direction. Reinstate the support broker roles and increase hours available where needed. That's been agreed to by MDH as well. Reinstate, I'm standing up because my light went off, and so now I can't refer to my notes. Reinstate self-directed overnights. Maryland Department of Health claimed they were doing it already, but what we discovered only in very limited cases where the individual had the resources, the network, the advocacy to get through the maze. The vast majority of people that really were challenged were not getting them. Mileage reimbursement for specialized vehicles. That means that if a neighbor has a van equipped to carry a wheelchair, that you can get reimbursed for the mileage for that van and not necessarily the driver. So not increasing costs, just shifting them. Parity in budgets, that has been achieved already. And individual family directed goods and services to be more flexible to needs. That taking therapies out will significantly reduce the fiscal note. And I do want to touch, since I've given you the recommendations of the work group, which translates right into the bill before you, I want to touch on the fiscal note. There are a couple of important points to make. One is that we're not increasing the budget of individuals who are utilizing self-direction. We're just asking that they have the flexibility to be able to use it. In the past, a lot of their money that was allocated to them was left sitting on the table because they couldn't access some of the benefits that came along with the original waiver in 2005. The waiver amendment, we had asked to do it 6 months earlier. If that's going to create additional costs, we can do it in July as anticipated. Same resources would have to apply for the waiver, just at a different time. As I mentioned, we've agreed to the required training for caseworkers already and expanded roles for the support broker. I might also note that in the fiscal note, which we have requested to be revised, and as you all know, it doesn't happen this early, but the author of the fiscal note has agreed to do it because some of the assumptions we've shared, as well as taking therapies out of the goods and service item, will significantly decrease the fiscal note. So when I mentioned that the assumptions are very high, support broker hours, the bill says up to 40. Not everybody's going to use 40. History shows that they will not use 40 because at one time we had 40 and they weren't fully utilized. Vehicle use, as I mentioned, this is just a swap. Instead of compensating the driver, you'd be compensated a specialized vehicle. And finally, overnights, the assumption for overnights is really very high in the fiscal note. We will get very shortly a written statement from the fiscal note writer stating that she believes that the assumptions will significantly decrease the fiscal note. I had hoped to have it today, but they're a little short-staffed. And I want to, if I could only reinforce one thing, it's that in reality, this bill doesn't change anything either financially or in terms of what was originally allowed in 2005 when self-direction first passed the General Assembly. We're not asking for anything that CMS hasn't agreed to. The federal government waiver will cover most of the costs. And finally, I want to reinforce each individual has a budget. And self-direction, which is very person-centered, allows them to use it as they want, as long as the items they want qualify for the waiver. We're just asking to empower them to be able to utilize those things and not have to go through a maze or not have to be denied what was rightfully given to them in 2005. I think that does it.
Thank you for your work. I appreciate it. I like to allow the department to address us because they were an integral part of those meetings. Ms. Check.
Thanks, Delegate. And thank you to Delegate Lewis-Young. We did a tremendous amount of work over the interim. I think I would just start by saying that's why the department was a little disappointed to see this bill. We came into the work groups and our understanding was always that it was to avoid legislation. So we were a little bit disappointed to see this bill again, because as the delegate noted, there were several recommendations made by the work group, and Secretary Schrader met with, I think Delegate Pena-Monick, you were also at the meeting, but we met with Delegate Lewis-Young and we had compromised and agreed to do several of the things that are in the bill. And we're working on implementing them now. I think the view of the department is that it's too much at once. We can't implement all of this at the same time. And we expressed during the legislative work group that, we were looking into things. We thought that things needed to be researched and developed a little bit further before putting it into legislation. We are revamping the overnight services, like Delegate Lewis-Young stated. We are revamping some of our training, doing more on that front. A couple things that I did want to point out in the fiscal note is that, excuse me, they are assumptions, right? We don't know how many people will participate and who will use these services. And so we tried to give a range. And I think we did 50%, 75%. I think the number that was given during the hearing was 5%, but we don't have any data to back up that it will be that low. And we are working on revising the fiscal note. To Delegate Lewis-Young's point, removing therapies does drop it significantly. I don't have the number off the top of my head, but I think it's in the range of like $60 to $80 million, something like that. So that was fantastic. I think the other thing that I want to point out is that I understand, or the department understands, that the intent is not to increase folks' budgets. But the reality is that when, and we might be able to work on some language to help tighten this up, but the bill as written, when you add additional services in, my understanding is that budgets are developed using the LTSS system, and that as you expand the number of services available, the budgets will follow suit and get bigger. And so I think we can there's probably room there to continue discussions, how we tighten it up so that we provide the flexibility without increasing those budgets. But we need to have further discussions on that. I think those are just the highlights, the main points that I wanted to hit. But I will just say, you know, we really are committed to continue working with the delegate and the, you know, I know the legislative work group is over, but that doesn't mean that our work is, and we are still committed to everything that we mentioned in the work group, implementing those and researching and moving forward on those. So I will stop there. Thank you.
I know there are a couple of questions, and what I'm going to do is ask the delegate to meet with Ms. Check and try to work on the bill, try to see if you could come to some agreement. We are meeting again this coming Wednesday, and we'll probably be meeting again as well. So I would ask Delegate Lewis Young to please meet with Ms. Check, okay? With that in mind, Delegate Belcastro and then Delegate Hill.
Thank you, Vice Chair Peña-Melnick. And Delegate Lewis Young, I want to thank you for all your work on this bill. I know you've worked incredibly hard and it's very important legislation. My understanding is that we are doing this bill to codify it so that our families in the future never have to go down this difficult road again. Is my understanding correct in that? All right, thank you so much. That was my question.
All right. So first, let me congratulate you, Delegate Lewis Young, on this amazing work. And I guess the question is really for Ms. Scheck. I think, you know, we've had a lot of people were devastated when the services that they were being provided with were taken away. And I can think of one particular example of a patient I know whose overnights were removed, her weekends were removed, and she's a seizure patient who actually requires somebody with her 24/7 so she doesn't have to fall down. And I met her because of having to sew her head up every time she fell down, and this was a solution that worked. So I guess my question is, you talked about the cost. I don't remember ever getting a report, and maybe you have the numbers, on how much you all saved for the state when you took away these services from the people who had been approved and had been receiving them. How much did we actually save? Because I'm not sure that was an impressive number.
Yeah, thank you for that question, Delegate Hill. I don't know, but I will certainly look into that and I can get that data for you.
All right, thank you. And I was ready to vote the bill today, but okay, thank you all.
Okay, Delegate Kaiser.
Thank you, Madam Chair. I often find here in the legislature that when people have their bills, they have discovered a serious problem, but I don't always find that the bills address the problem and are the right solution necessarily. But I am convinced in this case, and I've received so much mail on this, and I guess the question that I would ask is, and maybe this is to Delegate Lewis Young or maybe to Ms. Wopat, who is here, is without this, what happens? And what happens to the care of individuals? So, you know, bringing it back to the patient. And in a lot of cases, they're parents who are affected by this their whole life. So.
You know, I'm going to let Alicia answer that, because even though I know what happens when you don't codify something, I think she can give you a better answer on what has happened to the families as many of the components of this bill disappeared.
Thank you, delegates. I appreciate the opportunity to speak with you today. I think it's really important to mention a few things. One is that with all due respect to the department, we have been working with them for 6 years. There is really nothing new in this bill, nothing that we haven't discussed on multiple occasions. We meet monthly. So there's nothing new, nothing that they couldn't have agreed with, nothing that they couldn't have agreed with during the 7 months timeframe of Delegate Lewis Young's summer study. The other really important thing, I think, from listening to this committee do their work earlier in the morning, is that we were told by DDA, it's their policy as conveyed by DDA leadership, that the amount of an individual's approved budget is earmarked for the use of that individual for the entire plan year. And what this bill seeks is not additional money, none, very little or none at all. The issues addressed by this bill are flexibility and access to that earmarked amount, not additional increases. We have seen what has happened to families when the department and DDA changed their mind. We had overnight supports. People lost them. Grandmas are staying up overnight, not able to manage their own life. It really did risk several people's health and safety, not just the participant in the program, but anybody who is caring for them. We've seen with caps on family goods and services, people not get what they need, but the money is there. The money is already earmarked for that person. And we have seen what happens to people who don't get the support they need to continue in this program in a way that is both safe and healthy. And finally, I'd like to say that there's a number of people like myself who are aging, who have adult children who we want to protect and make sure that their lives do stay healthy and safe in the future. And that the items in this bill go a very, very long way to provide them the support that they will need when their family is no longer there to provide it for them. I hope that answers your questions, Delegate.
Thank you. And thank you for your advocacy. We appreciate it and all the time that everyone has spent on this. So we're going to hold the bill. Delegate Lewis Young and Heather, can you please get together? We're going to try to meet tomorrow after bill hearings to do the rest of the agenda as well, because we don't have time. It is 1:24 and we have a hard stop at 1:25. Thank you so much. I really apologize for those of you that were waiting for the last 3 bills. Fortunately, this is crossover week. And as you know, it is really, we have to be flexible. So I apologize. But Aaron will send out a notice about meeting tomorrow after bill hearings. Please put it on your calendar. Thank you for your patience. I really appreciate it. Delegate Kaiser.
Will we be coming back to any of the held bills as well tomorrow night? Thank you.
Okay, thank you. Bye-bye.